Right.
Oh.
Let's go, Joe.
So yeah, last week I watched a little webinar from a physio from Australia. He's a running physio, Brad Beer, and also just sort of tying that in with the article from last week. So talking about bone stress injuries, and so a bone stress injury sort of represents I guess the inability of bone to withstand repetitive mechanical loading, and that results in structural fatigue and localized bone pain and tenderness. These injuries occur along a continuum, and they sort of begin with a stress reaction, and ultimately, if they continue loading inadequately, they end up with a fracture. So here's a nice little graph of the continuum. So it starts off with so when we run, our bones, our tissues, our everything gets stressed a little bit, and this is normal, and our body is able to heal that through normal remodeling. So the bone gets a little bit damaged, but that's okay. It gets remodeled, and then it gets stronger. So you become able to tolerate more load. You're able to run faster, run further, run more often. If you were to continue sort of running at higher speeds, intensities, too often, this remodeling process might get imbalance between remodeling and sort of that stressed or damage. If this is continued, we get a stress reaction. So that is when the bone resorption, when the bone remodeling gets a bit too much, and then it goes along the couple of grades depending on how much you've stressed the bone or the whatnot. And then if you continue going along, that's when we end up with the fracture. So the further along we get in this continuum, the harder it is to get back to normal remodeling, and the longer, I guess, it takes, and the longer you need to let it heal. Does anyone have any sort of quick thoughts on that?
Yeah, I'll go first this time. So as you can see, it's a continuum of pathology. Avi, I just want to ask you, reaction to fracture. Yes, there's timing and weeks and stuff. What sort of things have you seen which delegate from reaction to a full-blown fracture? How do I ask that? Yeah, what would you be more concerned about, it being a stress fracture versus just a bony reaction, is my question. What you've seen clinically.
Oh, wait, what?
So can you see how it's a continuum? Okay.
Yeah.
Reaction at the bottom and fracture at the top. I was just wondering what you've seen clinically that would make you think, oh, this is more of a stress fracture, not an early stage reaction, and we might need to, I don't know, put them in a boot, further imaging, stuff like that. So what things are jumping out at you red flag wise or anyway wise to think where things sit on the continuum?
I guess just like how long it's been going on and how painful it is. I don't think I've ever really had to differentiate between a reaction and a fracture.
Yeah, well on that note, if you had to differentiate, how would you manage it any differently?
No.
Yeah?
Not really.
Yeah, to a certain extent.
Either way, you're going to do rest and strengthening stuff. So
yeah, just like grading for sure. Absolutely. And the other question which you asked last week, when would you boot someone if it was a foot? Yeah.
If it's like in a high risk location, like there's like certain oh man, I feel like this is a quiz, something I should know. Did a report on it.
You know, in these things, I'm just asking you questions because I just want to know your thoughts, but sure.
Oh.
Honestly.
There's like certain locations that are more like high risk for becoming like a complete fracture.
Yeah, absolutely. It says that they're on the slide at the bottom. It says that they're on the slide at the bottom. High risk stress injuries include a couple of those areas.
Oh,
I guess.
yeah, that. There we go.
So there's a few
That's
things
exactly
to
what
watch
I
out
was
for.
thinking.
Yeah. Booting is actually very interesting, which we spoke about a little bit, because both of the stress reactions we saw, we didn't end up booting, but they got good results by looking at those progressive load strategies, and offloading and looking at mechanics and stuff. And but back to your point, and just Jack, we didn't talk about this last week. If they're at a higher risk of, some of those more, suitable areas, we definitely should look at booting more quickly. And if you can make a note, we definitely want to order in some boots, because there's no doubt we'll be seeing more and more. For sure. Do you have any thoughts on that, mate, before we move
on? No, but there might be some coming in.
Yep. Cool.
I guess this carrying on, this micro damage formation is threshold dependent, depending on so it's dependent on, I guess, the amount of strain that is applied to that bone, how much, I guess, so the size of that strain, the bone strain rate, which is the speed at which intensity, I guess, and how often that bone is getting strained. Going into the sort of epidemiology, and so talking about those high and low risk areas. But just quickly, so bone stress injuries in competitive cross-country and track and field athletes ranges from 5 to 20-ish%. And it is sort of known to take up at about 20% of all running injuries. So they are quite prevalent, more prevalent than you'd think. And of particular concern is the high recurrence rate of bone stress injuries. So half of track and field athletes report a history of bone stress injury on more than one occasion. And about 10 to 12% of cross-country and track and field athletes with a history of bone stress injury sustain a subsequent one when in the following 1 to 2 years. So 10% of all bone stress injuries happen again very quickly following on. So it's very important to work out what's causing them, but also, differentiating between the high and low risk areas. So some of the high risk areas will go through the femoral neck, the anterior cortex of the tibia, the medial malleolus of the ankle, the talus, navicular, fifth metatarsal, second metatarsal, and the big toe.
Makes sense.
Makes sense.
There's your high risk areas, Harvey, by the way. You might want to
remember. I got it.
But it makes sense.
I think the big one not to miss is the femoral neck, because that's a big one there for big arteries and stuff going down there. So that could, I think, for
again, clinically, Jack, what would you be thinking if you're suspecting femoral neck as opposed to something differentially diagnosed? And what sort of population would you be thinking it in? I know it's rare, but it's just good to think about.
Teenagers, early teens. Sort of like that teenage sort of age group, I'm guessing.
Yeah. Did you have any thoughts about that, just with femoral neck? It's something I haven't actually can't even think about seeing. Have you seen that at all, or thinking about what?
Yeah, I actually had a patient that had a femoral neck. I think it was femoral neck. Stress fracture.
How do they present clinically?
Well, we didn't see this patient until like after they'd already gone to the doctor, but it was like restricted weight bearing for a while because they don't want it to get worse and turn into like avascular necrosis or
Correct,
something.
cool.
So,
do you remember how, or it might have been in the notes though, like did they present with certain signs and symptoms that really jumped out that suggested that, as opposed to just something else around the hip?
Honestly, not really.
Yeah. That's what my thoughts are. So it's really important to look into, because and not to miss, I think potentially even as things don't, you know, if things don't get better, you know, but of course it would be so hard to treat. What did you do actually, Avi?
It was all just based on like weight bearing, like from what the doctor had said. So
Yeah.
like just did a bunch of like non-weight bearing glute strengthening, and then started slowly to like building up to like walking and stuff like that, like getting rid of crutches. And,
Cool.
yeah.
Yeah, tricky. Have you seen, before we move on, Avi, have you seen any other of those high risk injuries in your internships or otherwise that you might want to talk about?
No, I don't think so.
Ours have been really base of fifth MT or around that area. In fact, one of the people we've seen, I think, is more cuboid, which is very interesting. Little hotspot. So it's interesting to see where they present and why they present. We'll get into the mechanics later, but yeah, just don't miss it. And clinically, that point tenderness, I think, is just so, for most of those things, is so important. If you touch them, they jump off the bed, you know it's probably going to be hot.
Cool. So going into some risk factors for bone stress injuries, so that can sort of group them in two different groups. Biomechanical factors, so that is the load applied to the bones, and that results. It's around sort of the training patterns, how much, how soon, how hard. The biomechanics of the runner, not so much, but it's a factor. Muscle factors, so how strong the muscles, tendon, bones are, and then footwear and running surface, again, not as much as compared to the training patterns and muscle factors. When we look to the biological factors, so that is the ability of the bone to resist load and prevent cumulative damage. Talking about the athletic history, so you know, are they a track and field runner? Have they been running for years, or are they a sort of a newly found runner because of COVID, going from barely running to trying to run a half marathon? The medical history, so any sort of underlying bone conditions, osteoporosis, etc. Another big one is their energy availability and their bone health. So we'll get talking into that. Calcium and vitamin D status, and then the sleep and life stress as well. So yeah, talking about energy availability. Brad, with the webinar last week, he was talking a bit about that, and it was very interesting. I never really considered it, but your energy intake has to match your, I guess, training load, and that seems, you know, that's a fair enough thought. But if you're going from, I guess, running 10K a week to, you know, a couple of runs a week, couple of 3Ks a week, or then trying to up that to 20K a week, running, you know, 5, 6, 7Ks each time, your energy demand is going to double, let's say, for that week for your running. So trying to match your training load with your energy intake is going to play a huge role in determining whether or not you get a bone stress injury or not. Any sort of thoughts with that?
Yeah, I'll go first because I saw this last week. Yeah, energy availability has just not been, it makes sense, of course, but I just probably haven't been discussing that enough with these sort of issues, and particularly looking at the female athlete triad. I think it's so important to really just make sure you consider it. How you implement it, I'd love to know as a physio, but it's definitely, I think, really important when dealing with those injuries. But I'm sure Harvey, being an athlete and in that space, might have some thoughts around the risk factors of energy availability and injury. So yeah, I'd love to hear your thoughts on it, Harvey.
Yeah, I mean, I think like nutrition is always important for like anything, but especially for runners, because like people with a female triad are have a way higher risk for getting stress fractures in general. But I don't know.
I'll ask again. As a physio, though, how would you embrace the subject, and how do you sort of help them implement that? If we know this is a thing that's really important for a good outcome, but we're not nutritionists or dietitians, like what do you do as a physio to try and give them good advice to make sure that when we look at the physio things, they're going well? If you don't just refer straight away, just out of interest, and it doesn't just have to be for stress.
Well, I don't know if it's different in Australia, but like we can't give like specific nutritional advice, but we can give like really like basic stuff that is essentially like available to the public. So, I mean, you can say like tell them about the importance of like protein and carbs and fat and like the ratios, but you can't really be like you need to have this many calories, and because we're not dietitians, so we're not like allowed to do that. But
cool. No, I'm so glad you said that. That's exactly what I would do. So looks like we're very similar with that.
So if it's like really a big issue, then you'd probably just refer out to a dietitian. But
I just feel like exactly what you said, Avi. Sometimes we're too quick to refer out straight away, when sometimes it can be something really simple, and you can have a conversation around just getting the right, energy in versus energy out, first of all, and get them to explain that, and talking about that if we've increased our workload, but we're not getting the right energy, and we're going to increase injury. So we can still do the basic stuff. We have the training to do that, but we don't have, if we said, I need you to get a calorie journal, or we give specific things like I need you to go into an intermittent fast, or I don't know, a low carb diet. I think we can't really push the boundaries. That's out of our scope. But for anyone watching this later, I think it's important to know there's stuff that we can do, and I believe we should start these conversations straight away, because good outcomes are dependent upon having these conversations. We could have the best progressive overload strategies in more of a physio box. If we don't think about these things, they might still break down. Jack, do you have any thoughts on that?
Yeah, I think it's just trying to identify it early, and it can be simply as not eating enough for your energy demand, but it can also be an excessive training load. And Brad was saying he was in this sort of category for years and years and years, because he would be physioing all day back to back, and then going on a big run afterwards. So it goes both ways, and just I guess trying to identify it early with your patients is key.
Yeah, I think just got to look at the big picture. That's definitely, I think we all agree with that, is important.
So I guess how to identify whether someone has a bone stress injury. So these are both taken from Brad's Instagram page. 5 signs that you may have a stress fracture. I just posted this on our page. Pain with a single hop testing is one of the main ones. So higher than sort of a 5 out of 10. And then that the pain sort of comes and goes and may just move around. We can't really pinpoint where the pain is coming from, but it just sort of is around there, around the sort of the site. Number 3, couple of weeks off didn't fix it. So bone injuries are going to take a lot longer, 6+ weeks to heal completely. So having a few weeks off probably won't fix it. And it's probably going to, be hurting it all the time whenever you load it. There's been a sudden sort of increase, obviously, in a training load prior to the onset of pain. Trying to work that out with your patient is a key. And then another one is that the pain isn't going away with time, but could also be worsening as you're continually loading it and persisting. Again, similar thing, 5 indicators of a bone stress injury. Big one is prior history. So another, as we said before, 10% of bone stress injuries will reoccur. Aching pain, that may include through the evening, so that aching sort of comes and goes pain. Difficulty weight bearing, obviously, and then pain and reduced confidence with hopping, and just that general feeling of it just not feeling quite right. I think sorry, I think my internet's just a bit slow. No, you're back. We're good. All right.
Yeah, cool.
So, yeah. Yeah, trying to identify those sort of signs in the clinic is key. Any thoughts with those?
No, I think they all make pretty sense to us. What would you say is the difference between bony stress and stress fracture in terms of those two slides, though?
I think it's hard to say. I think a lot of it would be to do with the history and how long it's been, affecting them, I guess, and how, probably how painful it is and how long it's been affecting them would be the simple answer. There's probably no simple answer really. It's that would be my go.
Yeah, absolutely. Any thoughts, Harvey?
Not really on that
No.
one.
Yeah, pretty much makes sense, I think. Yeah, let's move on.
On physical examination, the most obvious sort of feature of the bone stress injury is localized bony tenderness. But direct palpation might not be possible for deeper sort of sites like the femoral neck and some like spine sort of structures. So with symptoms at these sites possibly being provoked by specific bone loading tests such as hopping, the fulcrum test, and the sort of one-legged hyperextension test for the pars into articularis. But ultimately, I guess runners who display these signs and symptoms of a probable bone stress injury require imaging to confirm our diagnosis. So yeah, going more into more into the history in the exam. So yeah, that definitely the training load changes. Screening for energy deficiency, and that's sort of asking about irregularities of the menstruation cycle, libido, and erectile function.
Wow.
The big one is that, so that's I guess their big three signs of low energy availability.
That's a really good point. Wow, cool.
Tenderness on palpation, big ones. Single leg hop test, the big one. Those unspecific sort of bone loading tests for different parts of the body. Ultimately, imaging is going to be the main one. And if they're an endurance runner, you could have a high index of suspicion there.
Yeah, makes sense. I can ask you, so the energy, is it just saying that those things sort of draw out the energy so those systems don't work? What were they? Yeah, what was the screening? What did Brad mention about that?
He did have a speak about it, but it was more, I guess, they're just sort of three signs of those low energy availability. There is a questionnaire that it's like the Red S questionnaire, maybe, or something like that. There is a questionnaire that we can go through, that they can go through. I'll try and find that.
I was literally going to ask if there was a questionnaire, because I figured if there was a way to, you can't ask, are you low on energy? You can a bit, but if there was a way to identify that and objectify that, it'd be so helpful in treating not just these conditions, but just other ones in general. Like if people are really fatigued and things like that. It's really important. So
Yeah.
seeing that come through that we don't do as much. Have you heard of any energy expenditure quizzes or something along those lines? Well, you've come across it?
Not like a general one. There's like the modified fatigue impact scale, but I'm not sure if that's more for like MS.
Yeah.
I think, and then, but I don't know. I feel like the screen is like, well, at least for like menstruation cycle, if they're like have amenorrhea, that's like part of the female triad.
Absolutely, yeah.
So maybe it's just asking about that. I'm not sure.
That's what I want to know. I want to know if it's just questions you ask, or if it's literally, or if there is maybe a series of questions that indicate that you might be having negative energy expenditure. But it's either way. I think we all know it's important to identify and address. So, yeah, interesting.
Recovery time frames. We've got the 4 grades of how bad that stress reaction is. So the grade 4, we're looking at sort of 31, 32 weeks. So it's quite a while for a bone stress injury of a high grade to heal, compared to grade 1 still being a couple of months to heal. And that's, I guess, from injury to return to sport. And then the estimated delay in return to sort of running or whatever the stressful activity is over here. So grade 1 would be a couple of weeks, compared to grade 4 being 2 to 3 months. So it's quite a while off the aggravating activity for the bone stress injury to heal. And I think communicating that with the patient is big. So the rehab of bone stress injuries, again, looking at both biomechanical and biological factors. So the biomechanical relating to the training stuff you can do. It's important to highlight the importance of rest in between runs. So really optimizing that rest in between runs and returning to loading, stressing that try gradually working up to the training loads that they were once doing, and we can try and spread those training loads out, especially if they were a triathlete whose running is affecting them, trying to focus on swimming and biking to reduce the running load, but also looking at their energy requirements for each run. Looking into the biological, so that's our capacity to resist the stress, and looking at a lot of strengthening activities to improve our bone strength and bone health. So returning to run programs, there is that we've heard of the 10% rule, but that may not sort of apply to all runners. Because if I go to the next slide, the 10% rule, for if we were talking about high, say, runners who are doing 100K a week, 10% increase is another 10 kilometers a week. So that's quite a large increase for runners. Compare that to people who are doing quite relative low loads, say, who are doing 5 kilometers a week, or let's say a run of 1 kilometer. You would increase that by 10%. That's only really increasing it by 100 meters a run. So it might not be high enough to get those adaptations. So 10% rule, yeah, it's a great rule of thumb, but it might not relate to everyone. And trying to sort of identify which, what relative increase in load is going to be ideal for your patient. Trying to restoring run volume first, and then looking at terrain, and then speed work is last. So returning to the volume, then looking at hills, looking at different terrains, trail runs, and then speed is last. Just highlighting the importance of the recurrence rate of bone stress injuries, so really nailing that the initial rehab, and slowly building rather than getting back quickly and then busting straight away. When we're returning to running, we've got to sort of focus on, or highlight the importance of the harder runs or the high intensity run sessions, and trying to spread them out as best as possible. So planning your weekly routine is key. And then if you've got the ability to go to an altered G machine, use that.
Have you seen them before, Avi? They're just a anti-gravity treadmill.
Yeah, my last clinic we had one, which was really cool.
That's right, you did. You lucky duck. Yeah. I'd love to just have one just sitting out the back. It'd be really cool.
Yeah, they had all the fancy equipment at that place.
We've got an old school iPad that we need to upgrade.
Yeah.
Badly. Really interesting. I just want to talk about that capacity to load, because again, looking at this presentation, there's so much I feel like we're not talking about enough. When it comes to not just these sort of injuries, but a lot of injuries in general. I don't know what you guys think, but I just think it's important to introduce those conversations to help them get a clearer picture of a good outcome. Tissue tolerance, nutrition, sleep, psychological well-being, it all plays a part. I just feel like we're good that we talk about. We don't, I think we need to just acknowledge that a bit more if it's playing a part. What do you guys? You can go first, Jack. What do you think about that?
Just with like every patient.
Yeah, we can talk about it in terms of stress fractures right now, but I'm just looking at it going, man, I don't know if sometimes I acknowledge that enough.
Yeah, and it's just, I guess, something we got to sort of ask for, sleep's the big one. I think there was even in for bone stress injuries, there's something like if you're getting less than 8 hours sleep here, you're a more chance of getting a recurrence of an injury compared to those who sleep 8+ hours. So I think just asking the question and highlighting and trying to identify if there's an issue there with someone, not getting enough sleep or not getting the right nutrition or everything else. It all is affectable.
Yeah, absolutely. Avi, do you stereotypically on placement and now when you're physio, would you ask about those things? Do you bring it into later consults? What are your thoughts on those capacity low points?
I think it kind of depends on the person and the condition too, but I don't know. I definitely don't think I did it as often as I should have, because sometimes you kind of just get caught up in the stuff that we think is typical PT things, musculoskeletal questions, rather than like talking about nutrition and sleep all the time. But I think it is really important, and we were like taught to ask about these things.
I think Jack, we'll put it into our. If you should see our templates now in Clinico too, Avi, they've changed a lot as well. But we should definitely put it into our new patient templates just to make sure we acknowledge that, at least in that first session. And then, like Avi said, depending on the client, really looking at not poking, but getting more information about it, particularly if the client isn't getting as good a result as you'd like. I think, too often as young physios, we think, it must be my skill set. And I tend to disagree. There's so many other factors that lead into it. Injuries are complex, rehab is complex. And sometimes on 1% it can become a big thing. So anyway, I think it was just good food for thought, because, Brad's one of the best people in the world who deals with these injuries and who rehabs runners. So if he's saying it's important, I think it's something we should definitely think about.
Yeah, so that sort of, I guess, was the sort of end to the slides.
Cool.
Yeah.
Thank you, Jack. Well, what was yeah, we'll go around the room. What was the biggest take-home message from Jack's little presentation? You can go first, Darby, if you like.
I think it was just like a good reminder to look at more things than just like the load, but also looking at nutrition and sleep and all those things. Because I mean, I feel like I forgot to ask about that stuff a lot when it could be very relevant.
Yeah, absolutely. And
that's just like
even
a good reminder of how important it is.
Yeah, and like you said, just prioritize it. Like even if you do shortened initials and follow-ups, it doesn't mean you can spend some time just acknowledging that and saying what a part it can play. For me, it was just the energy expenditure specific question and looking at how that plays a part. And yeah, just not forgetting about those bigger pictures, like you talked about the female athlete triad, but there was stuff there for the guys as well. I don't know how you broach the subject of erectile dysfunction in a physio consult. We might have to talk about that another time. But I think it's important to think about. And man, imagine if you predicted that on someone. I think you'd have a client for life. Like, how did you know? Science, baby, science. So yeah, cool. What was your take home, Jack? That was a great presentation. Thank you, mate.
Yeah, I think it was the energy expenditure. I think if you take patient X who's gone from 20K a week who wants to do a marathon, and they've increased their training load really well spaced out. They're doing the 2 to 3 strength sessions a week. They're doing everything right, but they haven't increased their energy intake as much. You got to be asking those questions, and I think it's easily sort of forgotten as a patient and as a runner if they're going for that longer distance to just sort of not increase their energy.
Absolutely. And I think it's a great place to finish and summarize. Always reflect upon your clients' journeys, but if they're doing everything right, by the way, I finally cleaned up my computer and found all these PhysiTrack videos you and Carmen made, Harvey, and that are on there. So thank you for that, by the way. But I guess if they're doing everything right, they're following their exercise guidelines. If they have an app, they're ticking it off. You have to look at other things. It can't just be your skill set. And I think that's very important to look at. And those principles of capacity and load will be very relevant to almost any condition. And I think that's where we can set each other apart. So I'll stop